Um, so thank you for this invitation. I think this is a very important topic to discuss, and I think it's very pertinent for most of the anesthesia providers who are going to be potentially working on patients who have cardiac disease but have been scheduled for non-cardiac surgery. The aim for this talk is really going to try and demystify some of the aspects on the echo reports and see how we can interpret them. I get a couple of consults from anesthesiologists regarding echo reports and also whether the anesthetic that is going to be provided is going to in any way affect the results on the echo. So that is what the aim of this talk is going to be about. I have no specific disclosures for this talk. So just a bit of a background. All these guidelines relate to cardiac risk, especially for non-cardiac surgery. What is important about them is that they talk about major adverse cardiac events, and those include those listed there: myocardial infarction, cardiac arrest, cardiac death, potentially life-threatening arrhythmias, and on occasion may also include cerebrovascular accidents. All the guidelines seem to agree on it, although the definition for this is not very specific. There is also myocardial injury that is due to surgery or after surgery, and that is usually an increase in troponin in the first 30 days postoperatively. Seems to be associated with mortality. The means is actually considered to be, means and the methods are considered to be part of perioperative adverse cardiac events. So all of those combined are what we are mostly going to be worried about. But there are patients who would potentially be at risk. And of course, as you all know, patients who already have cardiovascular disease are already at risk. And patients who have a very poor functional status can only mean that perhaps the heart cannot handle the stress of the surgery, and therefore that may mean that their heart may actually fail postoperatively. The others are usually elderly patients. In Uganda, old age starts above 50, but globally the studies indicate 60 years and above. Then the other aspect, of course, is comorbidities. The thing about these comorbidities like diabetes, CKD, and hypertension is that they naturally will increase your physiological age. So if you're 50 years and you have two comorbidities like DM and hypertension, naturally your active physiological reserve is going to be closer to 60 and 70 than it is to a 50-year-old without those comorbidities. So those in themselves increase the risk. And so you have to be cognizant that patients who have more comorbidities and they're old, they're probably at risk. So there's the patient side and then there's the surgical side. Normally, most elective surgeries will have a low risk, usually less than 2%. Once we hit 5%, you probably have a high risk surgery at that point, and some of those have been categorized. And that is all surgery that will include intraperitoneal, include large cavities, except of course for the cranium. All the other surgeries that have large cavities being worked on will be high risk surgery. Then of course vascular surgeries of all these are the most high risk because of the endothelial injury that happens with that. Long procedures have the same impact. Lower risk surgeries would include some of those. So breast surgery falls into lower risk simply because of the less interaction with the vessels. You're mostly dealing with fat tissue, which is not well vascularized. So what we have to note is that the most accurate assessment is probably going to be combining patient-specific factors and procedure-specific factors, and a couple of scores that can be used for this. The surgeons have their own that is derived over large data sets to combine these two specific factors and procedure-specific factors. Allows you to be able to estimate the actual risk, which is quite excellent. If you use only one side, it may not be appropriate, as we shall see later. So the importance of assessing the risk for these patients is to first of all allow prognostication with patients and families, as well as optimization of preoperative status, and then plan for the surgery, and then plan for the postoperative period. So the whole point for risk assessment is to achieve that. The thing about the echo, which is now what we are going to be largely talking about, is that it's going to give you a lot more information relating to the function of the LV as well as the RV. Most importantly, you shall see later on, the systolic function is the most crucial part. The diastolic is less crucial, but it still has to be considered. And then, of course, the structure defect, how the chambers are, the sizes, the outflow tract, all these things affect the cardiac output. And then, of course, if you have septal defects, whether they are atrial septal defects or ventricular septal defects, or sometimes the patient has had myocardial infarction, they can get ventricular septal rupture, which will be like a VSD in a way. So you have to have all these considered and before you actually take this patient in. So why is this important? If we look at this study done and published in the JAMA, looking at left ventricular ejection fraction and the symptoms relating to mortality for elective non-cardiac surgery, you can see in this table, they basically categorize heart failure, without heart failure, and then those who had heart failure, compared again with those who had preserved left ventricular ejection fraction. So when you have heart failure with preserved left ventricular ejection fraction, you basically have diastolic heart failure. The rest of them are systolic heart failure, and so mildly, moderate, and severe are based on the ejection fraction of the patient. And so if you're less than 40%, you can see on this end that the risk of mortality exponentially increases. So if you have if you look at the adjusted odds ratios for patients with moderately reduced left ventricular ejection fraction, they are nearly 2 times more likely to die compared to those who have preserved. And so that is something that you have to actually consider if you're going to work on a patient whose ejection fraction is lower. If it's less than 30%, then you have to be extremely cautious with this patient because they're likely to fail postoperatively. Their heart does not have enough reserve to handle the stress. The other aspect is about being symptomatic versus being asymptomatic. Certainly, if you have heart failure and you're asymptomatic, you're probably less likely to have issues. But of course, having heart failure in itself has a bearing on mortality compared to those without. What is important is those who are symptomatic are more than 2 times more likely to die compared to those who are asymptomatic. So again, regarding the complexity of the surgery, you can see at this point that those with heart failure, depending on the complexity of the surgery, it exponentially increases. And so if you have heart failure, the complexity of the surgery is going to increase the odds of mortality. And we're going to look at some cases relating to that. So this is basically a summary. If you have a left ventricular ejection fraction of less than 30, there's a 2-fold increase in the odds of death. And if you have symptomatic heart failure, the about 30% increase. So the point is, patients who have systolic heart failure are not good candidates for surgery. However, there is room to allow you to optimize them, as we saw earlier, in terms of risk assessment. And the echo is going to help us to do that. So in most instances, what we've requested for our patients have been what we regard as resting echoes. But there are also there's a type of echo called the stress echo, in which most times you give the butamine to stress the heart. You basically titrate it upwards from about 2 mics per kg per minute or 5 mics per kg per minute up to as high as 40 mics per kg per minute. The point is you want to increase the heart rate to the 80% maximum heart rate, 80% of the maximum heart rate that is allowable for that patient. So if you have a 50-year-old, the maximum allowable heart rate will be 220 minus 50. And so you want to target about 80% of that. And when you do that, when you look at this side or on the left side of your screen, you have a heart that is fairly contracting well before the debutanate stress test. And you can see it here. And then below here, you can see after the debutanate stress test, when you look at the ECG here, it is not as fast as the ECG down here. And so that tells you that this was done before the debutanate stress test and this is done after. And you can see the akinesis of the apex of this left ventricle. It's the same thing that we see here. The aortic valve is here. So what this type of echo is slightly different because it's called the it's a TDI sort of echo that allows you to look at the tissue much more closely and gives you increased sensitivity in looking at regional wall motion abnormalities. That's a little complex, but don't pay attention to that. The point is the cardiologist will tell you the regional wall motion abnormality, and then they will recommend that perhaps this patient has a coronary angiogram and the PCI done so that they can go through the operation without worry that they will have a coronary artery, either they will have an acute coronary syndrome, either intra-op or postoperatively. So that is one way we can do it. The other way is to do exercise and still we want to raise the heart rate of the patient. So either one of them could allow you to be able to detect this regional wall motion abnormality. So we are going to mostly focus on resting echoes of patients, and that's what we are going to go through right now. So imagine you have a patient who has had, who is scheduled for a right hip fracture operation by an orthopedic. And this patient has diabetes and has history of heart failure. And this is the echo report you've been given. One of the things you want to start off with is, of course, make sure that the echo report belongs to the patient for whom the procedure has been scheduled. So starting off with the patient ID, the indication for the echo. And then, of course, it's really important for you to look at who did the echo. Why? Because different cadres have different competencies, and therefore you have to be cautious on who you're going to trust to read this echo report from. As you'll see later on, there's an echo report that I've put in for you guys to kind of think through on where the error could be on that echo. So that is where you want to start. Then the next thing you want to go ahead and look at is the ejection fraction, because that is going to tell us about the systolic function. And we already seen that the systolic function is extremely important. This particular patient has a systolic function of 35. And when you look at the side here, the normal should be 50 to 75, and 35 falls in moderately reduced. And so we said with the reduced systolic function, there is an increase in perioperative mortality, as well as getting a major adverse cardiac events. So this is something that you're going to look at next. So there's two ways that they may do this. They may do it with a Simpson volumetric ejection fraction. Don't worry about that technique. The important thing is the Simpson is usually the most accurate compared to the standard ejection fraction that is done. It's usually more accurate. But as we can see here, it's 31, 35. The difference is still putting us in moderately reduced. So no worries there. And then the next thing you want to look at is the RV systolic function. There are two ways we usually assess this. In most instances, people will perform a TAPSE and or fractional area change. The question is, what is a TAPSE? It's really the tricuspid annular plane systolic excursion. So if you look at this image here, you have left ventricle, left atrium, and that's a mitral valve. And then you have the right ventricle, right atrium, and that's a tricuspid valve. The way the tricuspid valve moves is that it actually moves towards the apex. When you look at it here, it's trying to move towards the apex during systole. So what tricuspid annular systolic excursion is really us putting, as you can see in the image here, you put the M mode on the tricuspid valve annulus, and then down here, you're trying to look and see the distance between the highest point and the lowest point. And that is what they call the systolic excursion. The higher it is, the better the function of the RV. So if the systolic excursion is more than 1.5, that is normal. In this patient, it is 1.1. So that will fall around moderately reduced TAPSE. And so that gives you an idea that your right ventricle is probably not functioning well. And if your left ventricle is not functioning well, right ventricle is not functioning well, that should be a cause for concern. So basically you have biventricular failure at that point. And then the next thing after looking at function is look at the valves. Are they working normally? If they are not working normally, are they having regurgitation or are they having stenosis? And if they're having either one of them, the question is how severe? In most instances, we are going to be interested in severe mitral regurgitation or severe aortic regurgitation or severe tricuspid regurgitation, because in that case, the effects of our anesthetics are going to be much more pronounced on the hemodynamic. When it comes to stenosis, even the moderate stenosis is of concern. The mild stenosis is of less concern, but moderate stenosis is of concern. Severe stenosis, you have to be extremely worried simply because when it comes to stenotic valves, anesthesia and stenosis are not compatible in any way. Anesthesia is more compatible with regurgitation simply because in most instances, it's going to reduce the systemic vascular resistance or it's going to reduce the pulmonary vascular resistance. And so it allows regurgitation to reduce in that sense. However, if it is stenosis, systemic vascular resistance dropping is a bad idea for stenotic lesions. And so even if it's a moderately stenotic valve, you have to be really concerned. So in this patient, they have a normal mitral valve with a mild MR that is inconsequential. And then they have the other valves are competent. They have a trace pulmonary regurgitation, that's the PR. The tricuspid valve is normal, but there's a moderate tricuspid regurgitation. And we are going to, and so that again is not important, really. It's not a big issue. But the thing about moderate tricuspid regurgitation is that whenever an echo report shows you a tricuspid regurgitation, one of the things the cardiologists are going to give on top of that is the gradient on that tricuspid valve. Why that is important, it tells you about the severity of pulmonary hypertension. So after the valves, the next thing you want to see is there pulmonary hypertension in this patient. And usually when you have a tricuspid regurgitation, they will tell you about whether pulmonary hypertension exists or not. And they usually assess that pressure, and it can be estimated as the right ventricular systolic pressure or the pulmonary artery systolic pressure. If it's more than 60, so what you see here, the TG max of 47 millimeters, to estimate the right ventricular systolic pressure or the pulmonary artery systolic pressure, they add that to the right atrial pressure. So if you add 47 to 18, you'll get a value probably above 60, somewhere above 60. So that will tell you that you have severe pulmonary hypertension. Moderate pulmonary hypertension is not as worrying as severe pulmonary hypertension. You have to be extremely concerned when it is severe, because at that point, your anesthetic, some of them will help you, while some of them may not help you. If you're going to use vasopressors, some of them will increase the pulmonary vascular resistance, some of them will not. But most importantly, if you're going to give a general anesthetic, you're going to probably put this patient on positive pressure ventilation, and therefore that means you will probably increase the pulmonary vascular resistance and increase the severe pulmonary hypertension, which will eventually make the right ventricle fail. The beauty of this is that oxygen is a powerful pulmonary vasodilator, so you counteract that in the process. But if you do not know about this, then you're going to do everything probably wrong. So the other way we may know, the other thing they may report on severe pulmonary hypertension is maybe a flattened interventricular septum or a D-shaped LV, and this is what they look like. So on this left side, it's a normal left ventricle that is nicely round and it is contracting pretty well. If you look on the right side, you have a D-shaped left ventricle and you have a very dilated RV. Once you see this, you can see this interventricular septum is actually straight compared to this one. And of course, it is straight and therefore giving a D shape of the left ventricle. that means there is severe RV strain. And even if there is no tricuspid regurgitation, you are certain this patient has severe either pulmonary hypertension, or they have outflow tract obstruction, or they have, and can be so many reasons that could lead to that. So going forward, pericardium, this one is not so important to the anesthesiologist, except in instances where there may be an issue that maybe there is a massive pericardial fluid that needs to be drained before the surgery. In most instances, when cardiologists do this and they see an issue with pericardial fluid and it's massive, they probably tap it and drain it. That's before you even see this echo report. In other instances, with the abundance of tuberculosis in this country, you have to be concerned with TB pericarditis. So the thickening of the pericardium may actually cause constrictive pericarditis, which may compromise on the function of the heart. So these are things that you probably want to consider before you take this patient on table. One of the biggest challenges, I'm sure we've all largely been looking at the echo reports and just looking at the conclusions, but the idea here is for us to have an idea of what to look for. So the other thing that will be of concern, and we talked about chamber sizes as one of the other important things, is to look at the parameters and the values. So every time you see on an echo report a small d or a d at the end, RV is easy, LV is easy, that is right ventricle, left ventricle. When you see a D, it means diastole. When you see S, it means systole. The other abbreviation you probably see is IVS. This is interventricular septum in diastole. And then PWD is posterior wall diameter. Sorry, I made an error there. So this echo report is not well designed. Usually RV small d, it may mean diastole or it may mean diameter. Some other echo reports, a capital D would indicate diameter. So like here, IVSD, it refers to diameter of the interventricular septum, and PWD refers to the posterior wall diameter. So these are simply to measure the thickness of the interventricular septum, and this is to measure the thickness of the posterior wall diameter of the left ventricle, and if it is really huge, then you know that that is left ventricular hypertrophy. If the IVSD is also big, more than 1.1, there is some ventricular hypertrophy. While the RV small d, that's RV in diastole, if it is large, then it will mean here in this case, it is about on the high normal side, so it is dilated. The LV diameter, the LV diastolic diameter, that's in diastole, is 5.3, which is not within about range. And then when you look at the other one, AO refers to aorta, and that's mean they measured the aorta, and then the LA refers to the left atrium. We've heard the same TAPSI. FS is really fractional shortening of the left ventricle. It's not important. The important thing here is to look at the chambers. Are they dilated? Are they hypertrophied? So for hypertrophy, you want to look at the PWD and the IVSD. Those refer to diameters of the left ventricle walls. And then in terms of dilatation, you want to look at the RV in diastole, the LV in diastole, to estimate whether they are dilated or not. The other thing about the chamber sizes is that they will indicate the hemodynamic effects of the lesions that the patient may have. So for example, if the patient has hypertension, you would expect that they should have LV hypertrophy, and therefore the IVSD and the PWD should be much wider than 1.1. If it is, it's the RV that is experiencing very high pressures, the RV diameter may actually be dilated because of too much volume, and they may actually report within the detail of the report that the RV ventricular size is probably thick. And of course, you may also see that on the ECG. So the other lesions that you probably want to look out for will be intracardiac shunts that could be VSDs or ASDs, or they may actually report on the outlets of both the RV and the LV in case there are issues there. And then they may also report on extracardiac shunts like patent ductus arteriosus. So those are that is basically how you want to go through this. You want to start with the patient ID, the date, and the reason for the echo, look at the LV systolic function, then the RV systolic function, the valvular function, then the pulmonary hypertension if it's present. If it's absent, well and good. Then you want to look at the pericardium and the pericardial space, and then look at the chamber sizes and see if they're consistent with the hemodynamics of that disease that the patient has, and then any other abnormalities that exist in that case. We are going to go ahead and try and look at the different common lesions that you may encounter, especially when you get an echo done. So our case here is a patient who was scheduled again for hip surgery, but this was between 80 and 90-year-old. Again, you want to start off with identification and then knowing who did the echo. A physician versus a cardiologist, I think you would expect more proficiency from a cardiologist, but that does not mean that you throw away the echo report and move on with your life. It is important to read through what they got and see if it actually makes sense. And so, like we said, we start off with the ejection fraction. In this case, the patient has an ejection fraction of 24. This is less than 30%. So we are in big trouble if you're less than 30%. It can only get worse in the postoperative phase before it gets better. Then the next thing, you want to look at the TAPSE. In this case, this is a tricuspid annular plane systolic excursion, and it's more than 1.6. They said more than 1.5 is normal, 1.7 is perfectly fine. So already we can see this patient has a poor systolic function, but their right ventricle is probably working well. Then we want to look at the valves. They have reported that this patient has a severe mitral regurgitation, severe tricuspid regurgitation, and the pulmonary artery pressure is about 50. They have a moderate aortic regurgitation, a mild pulmonary regurgitation, and the pulmonary end diastolic pressure is about 5. So usually, like I said, if you have a stenotic lesion, you should be extremely worried because anesthesia and stenotic lesions are opposite. They do not usually work together. If you have mitral regurgitation, the biggest concern here is going to be really fluid because you have backward pressure of volume into the lungs. So that's going to be the biggest worry. But because anesthesia tends to reduce the systemic vascular resistance, it ceases to be much of a worry unless, of course, you're going to give this patient too much fluid, then you'll overload the lungs. So this is where you want to look into the severity of the regurgitation, but at least you do not have stenosis. That would be even of more concern. Then after that, the next thing you want to look at is the pulmonary hypertension. Again, to get the right ventricular systolic pressure, we said you can get the gradient across the tricuspid valve. In this case, it is 50. You could add it, the cardiologist will add it to the CVP if they measure it, or if there's a pulmonary regurgitation, they will add it to the pressure from the pulmonary regurgitation. So this is about 57. If you add these two, we said above 60 is severe. So this is falls into a category of moderate. So, and then the other thing you can see here, they say the interventricular septum is akinetic. So these are things that you sort of look for if you're looking for pulmonary hypertension. And so we know that this patient has at least moderate pulmonary hypertension. It may not be of big concern, but why they have it is of concern, should be of concern to you. Then we said normal pericardium, yeah, that's not much of a big deal. And then when you look at the chamber sizes, again, the right ventricular diameter in diastole is 4.8, which is far bigger than 3.8, which is the upper limit for this patient. And therefore, that is consistent with having pulmonary hypertension. If you look at the left ventricular end diastolic, left ventricular diameter in diastole, it is 6.1, which is much larger than the upper limit. So we are certainly dilated. The left ventricle and the right ventricle are dilated. The diameters are wide. Then if we look at again, if you see LVS, this is LV diameter in systole, it is 5.4. That means it is dilated. It should be less than 4. When in systole, the diameter of the LV should shrink even more because the LV is trying to eject. And here it is only shrinking and it's not going below 4, which means this is LV dilatation. If you look at the thickness of the LV, it is within normal thickness. If you look at these two, it's within normal thickness. but it's definitely dilated. So that one is something that we are sure of. The left atrium is also dilated if you look at the upper limit for the left atrium. So all these chambers are dilated. The question is why? If you look at the valves, we say there's severe mitral regurgitation, there's severe tricuspid regurgitation, there's moderate aortic regurgitation. Regurgitations cause dilatation, while stenosis tend to cause hypertrophy. That is the rule of thumb. And then, of course, the right atrium here was not included there. It's been put here at 5.8 by 5.8. It should be approximately the same diameter as the left atrium, but here it is grossly dilated, which is consistent with the pulmonary hypertension, the tricuspid and the severe tricuspid regurgitation. So this patient actually has a dilated cardiomyopathy. So the conclusion actually makes sense, and it ties in with the lesion of the patient in terms of having severe mitral regurgitation, severe TR, as well as a moderate pulmonary hypertension. So it makes sense. We don't have any other lesion in this patient. We can jump right into how would you give anesthesia for this patient? What is the prognosis if this patient is actually going to have a hip surgery? What would be your choice? First of all, what's the prognosis? Would you make it off the table if you have an ejection fraction of about 24? That's something you have to think about, and that's where you have to discuss with the family. Is there a way we can optimize this patient to reduce the risk of postoperative mortality? Or if they are this old, if let's say they are 89 and they have this cardiac disease, could you just leave them be and just palliate them? Or should you try and give them surgery, knowing full well the surgery will correct the hip, but they may never really get their previous physical functionality because of the procedure itself. And then, of course, you're going to predispose them to other debilitating scenarios, like not being able to move, and therefore putting them at risk of DVT, PE. These are things that you have to really think about and discuss with the family, as well as the surgeon. And then, of course, in most instances, the cardiologist will say, you can proceed with the case, but with caution. But you who is giving the anesthetic, you know the impact of what you're going to do, and so you should take that into good consideration based on the prognosis. If you can't give them adequate preoperative optimization to reduce the risk, then it can only mean that that is the best you will have. If you can, then you have to set targets and put time limits to that and decide when you're going to stop. Then, of course, will you proceed with the surgery? That's a very good question that has to be discussed in context beyond the echo report, but the echo report augments the argument that could be against proceeding with the case. But if you so choose to proceed with the case, you have to decide what kind of postoperative care you will need. This kind of patient, if you proceed in high-income countries, they may proceed because of the support structure they may have, but that's because also this patient has to end up in an ICU on invasive blood pressure monitoring, both CVP and arterial, and potentially they will have a good epidural catheter, they will have very good rehabilitation services, physiotherapy to come and help the patient. So this patient will probably have all the resources they need, but if you are in a low-income country where the resources are extremely limited, you have to think through what you're going to do. If you're in a private practice setting, then you have to be ready to provide care or almost equal to that is provided in a high-income country to give them a chance to survive. The second case is the young lady. Again, these are all echo reports that I've been consulted on, who was 24 years old. She was a PG, 24 weeks of amenorrhea, and she had features of heart failure. Again, you want to make sure that you look at the you look at who did the echo, which patient is this, what's the reason for this echo, and so you start off with the ejection fraction 73%. That is pretty good. The thing about a good ejection fraction is that you have less worry about it. If you look at the TAPSI, excellent. If you look at the valves, that is where the problems begin. So we have a severe mitral stenosis. Like I said, stenosis and anesthesia, not very good companions. And then, of course, you have a mild mitral regurgitation. In this case, we don't really care about the mild mitral regurgitation. We are caring more about the severe mitral stenosis. And then when you look at the moderate tricuspid regurgitation, when you look at the moderate tricuspid regurgitation, you can see that the gradient across it is actually pretty high. And so that means that we probably have severe pulmonary hypertension in this patient. It's already 75, so you can probably estimate that we definitely have a right ventricular systolic pressure of above 60. The pericardium is normal, which is consistent. And so you have to think through, okay, the chamber sizes. If I have a stenotic lesion at the mitral valve, I should expect that the left atrium is extremely dilated, or at least dilated minimum. So if you look at the chamber sizes, the right ventricle, it seems fine, 3.1. The diameter of the left ventricle seems within limits. The systolic diameter is also fine, or slightly smaller, simply because the mitral stenosis is not allowing a lot of volume to enter the left ventricle. So that is consistent. If we look at the left atrium, it is 4.8, which is much bigger than it should be. And then the thickness, the interventricular septal diameter and the posterior wall diameter of the LV, they're also within limits. So this patient doesn't have a thickened LV. It's just a small cavity LV based on what we are seeing on this side. So that is consistent with mitral stenosis. So it makes sense. And so in this case, if you have mitral stenosis in a young lady who is going to, who is 24 weeks of amenorrhea, and you've been called in as part of the team to be part of the planning for her delivery, you have to be cognizant that if you have to go for surgery, then you have to use an anesthetic that is not going to significantly drop her systemic vascular resistance. So prognosis would be good if you do everything right. And of course, preoperatively, optimization is necessary. So you have to have the cardiologist put on medication to control her. You have a lot of time up to the time she'll be at term, but this is the kind of patient you may not let go at term, but in case they get there, you probably are going to have to provide relief for her to avoid very high heart rates and also maintain the systemic vascular resistance. If you're going to proceed with surgery that is cesarean section, then you, like I said, you have to consider your anesthetic, you have to consider your heart rates and your systemic vascular resistance, because those are going to be the key factors in getting this patient out. And then, of course, postoperatively, is going to have to end up in a minimum of an HDU, probably requiring invasive arterial blood pressure monitoring under ideal settings, or you put her in an HDU where you have enough staffing to allow monitoring to be maintained. The second last case is about a 15-year-old girl who had a large VSD and was scheduled for laparotomy. So this girl, again, you have to start with identification, and I won't go into that, but importantly, you want to look at the ejection fraction. What I will tell you is most patients who have intracardiac shunts, they are going to have an overly exaggerated ejection fraction. So if you have a VSD, for example, a big part of that blood is going to be shunted through the VSD into the pulmonary vasculature, simply because it is a low resistance pulmonary vasculature, so it will allow a lot of volume to go. So the LV will seem like it's doing an excellent job. So it is excessively high ejection fraction, which is consistent. And then the RV function, in this case, we have RV ventricular hypertrophy with good myocardial contractility. Usually, if you're this old and you have a VSD that is large, odds are your RV is going to hypertrophy over time, because the VSD has allowed so much pressure into the pulmonary vasculature that you start to get pulmonary hypertension. So when you see a right ventricular hypertrophy in a VSD, you should raise your eyebrows. Is there something wrong in the pulmonary vasculature? If you look at the valves, they are mildly regurgitant, it's not a big deal. But if you're looking for pulmonary hypertension in this case, then you have to look at the pulmonary artery systolic pressure. It is 66. That means it's actually severe pulmonary hypertension. And one of the things that the cardiologist may report, they will say something like it's 2/3 the 2/3 systemic RV pressures. What that simply means is that this 66, which is the systolic pressure of the RV, divided by the blood pressure, the systolic blood pressure here, it is 2/3. And that is actually, or should be worrying. for you. The pericardium is normal. The chamber sizes, as you can see, the left ventricle is dilated because it's 5.2. It's dilated. We talk about dilatation in diastole, it's 5.2. And as you can see, the left atrium is also dilated. It is 4, which is far above what is consistent for a 15-year-old. And so that means that the VSD has caused the left side of the heart to dilate, which is consistent with VSDs because of too much volume on the left side. That tends to happen. The right ventricle is hypertrophied on the other hand, and that is usually a result of pulmonary hypertension. Other lesions, where they say it's a VSD, it's a large one. Thankfully, it's still a left-right shunt. The moment it starts to become bidirectional, you are headed into pressures in the right ventricle and pressures on the left ventricle almost being equal. That would be extremely worrying. But this does not mean this patient is still not worrying. This patient is worrying because they have severe pulmonary hypertension. However, thankfully, their intra-atrial septum is intact. So if this patient is scheduled for laparotomy, you have to have a discussion with the surgeon, the family, and let them know what the impact of the surgery is going to be, because postoperatively you're going to have stress, that is standard. So for long procedures or for complex procedures, that will be an issue. And then of course, you have to proceed. If you have to proceed with the surgery, what's your anesthetic technique? You have to be very, very concerned about the severe pulmonary hypertension, not to worsen it. So you have to use pulmonary vasodilators. The most powerful that we all have on our fingertips when you're at work is oxygen. So that means you're going to have to consider having a higher FiO2 than usual. And so you have to consider also the way you're going to ventilate the patient, try to minimize the pressures, and then and then of course try to allow a good expiratory time and all these things. So basically, you have to optimize these patients intraoperatively to avoid them getting higher pulmonary pressures. But because the left side is also dilated, you also have to consider that too much fluid in this patient may actually be detrimental to them. Otherwise, you end up flooding the lungs. It's important, of course, before you go in to have the patient well optimized. So the cardiologist will put them on medication to reduce the heart failure, as well as probably they may consider putting them on pulmonary vasodilators, but that is rare when you still have a left to right shunt, because you still end up reducing the pulmonary vascular resistance too much, and then you'll end up flooding the lungs and then going into heart failure, which they may not do. So I wouldn't request for a pulmonary vasodilator in this patient unless it is a bidirectional shunt. In other words, on occasion it will be left to right, and some occasion it will be right to left, but this one is purely left to right. So there's still lower pressures on the right side. And so you don't want to drop them any further because you'll end up flooding the lungs. So if you're going to proceed with the surgery, you have to consider the postoperative care based on the problems you have. But again, this decision should be made in context of the patient and the history, examination, other investigations, and the echo report is simply going to support you in your decision. Finally, we have a patient here who is an 85-year-old scheduled for CBD exploration. There's something wrong with this echo report. So if you go through the process, you've identified it was done by a physician. Okay, ejection fraction, usually it's the EF here, it's 50. Okay, the TAPC, do we have a TAPC? Yes, it is 1.6. Here they put a very high limit. 1.6 is okay. So there is a good RV function, systolic function. Okay, after that, you probably want to go ahead and look at, so the function is fine, the TAPS is fine. You want to look at your valves. If you look at the valves down here, you have, so basically you want to look at severe TR, okay? Severe tricuspid regurgitation. They put a gradient of 342, and then the IVC collapsibility, don't pay attention to that. Just look at the RV systolic pressure of 362. And once you read that, that is almost impossible. There is no way you can have an RV systolic pressure that is nearly 3 times your left ventricular systolic pressures. That is a technical error. And so there is no way this echo report can be accurate. And so you need, at this point, you probably just stop and ask them to redo the echo. There is no way. This patient should be dead. At 362, if your RV pressure is at 362, there is no volume that's going to go to your left side. And so this patient should be dead as the measurement of this. It is extremely rare, so it must be a technical error. At that point, I would stop reading the echo and ask them to just redo it, because if my PST is this high, this patient should be dead, and therefore we cannot trust everything else that we are going to read. If you want to read everything else, you can go ahead, but everything else does not tie in well with this RV systolic pressure. Okay, if you say you're going to look at the right atrium, do they have the right atrium here? They probably didn't. Yeah, it's here. It's 3.4 by 4.0. It's very unlikely that the right atrium will be of normal size. Anything less than 4 is about normal. It's very unlikely with this pressure that this right atrium should be normal. So as you can see, nothing ties in when you look at this this echo report. So the chambers do not tie in with this pressure, so you just drop it and tell them to repeat another echo. So in summary, we want to basically look at the ID of the patient, the date it was done, basically go through the structure, LV, RV, and then look at the valvular function, the pulmonary hypertension, pericardium, chamber sizes, are they consistent with the hemodynamics of the disease? Are there any other abnormalities? And after that, you're done with the echo report. Thank you very much. I will stop there and take any questions. Over to you, Bernadette.
Thank you, Cornelius. That was thorough, to say the least. For everyone that joined us a bit later, welcome. This is our first session in a series called 60 Minutes of Anesthesia that we'll be having every month. Please type your questions in the chat. You should be able to see it at the bottom of your Zoom. Okay, so there are no questions in there yet, but I have a question for you, Cornelius. There's one of the commonest echo reports I've seen, conclusion is grade 1 diastolic dysfunction. It almost feels like everyone is given that conclusion. Should we worry about it, or is it something that's quite common in our population?
Yeah, so whenever you see diastolic failure, usually you have to think about you have to think about again, I haven't paid much attention to the diastolic failure, because whenever you have diastolic failure, it's actually regarded as heart failure with preserved ejection fraction. So unless there is systolic failure, we call it preserved ejection fraction. So if you have grade 1 diastolic failure, I am not worried at all. Grade 1 diastolic failure is usually found in patients who have hypertension and they have left ventricular hypertrophy. So when they assess that, you literally find that the left ventricle, because of its thickness in diastole, it is not relaxing enough, or the cavity is a little small, so it's not allowing enough blood to flow into it from the left atrium. And so they have a degree of diastolic failure. If it is grade 3 and above, then the concern there is going to be that this patient, because of the limitation within the left ventricular cavity, they're going to have back pressures into the left atrium and then into the lungs, and then they will have pulmonary edema. These patients usually are all going to be on either antihypertensives, or they're going to be on beta blockers to allow enough diastolic time to drop that diastolic failure. But grade 1, never worry about that one. If that's the only thing you see on the echo, that echo is as good as normal, at least for an anesthetic.
Okay. That's a relief, because I think I've been ignoring some of them and just assuming it's normal. Someone's asking about the recording. So we have a website and we also have a YouTube channel. So these CMEs are recorded and they'll be uploaded to our YouTube channel later. just keep checking to see when it's uploaded, and maybe we'll send out reminders about it. Yeah, another reminder is that we have a call center for all anesthesia providers, all health workers to call in and consult in case they have difficult patients or an echo, in this case, that they need to discuss with somebody. The number is at the bottom, the right bottom corner on your screen. Save it, take a screenshot, and we keep sharing flyers around. Okay, so we have another question, Cornelius. Do you have any comment on doing echoes routinely for people who are above 50 if they're having elective surgery? Do you think it's necessary?
No. I think the one of the vices we are getting in this country, and it's because of technology, is that due to our increased capacity to just look into the heart, we are forgetting the clinical component of assessing patients. So if you have a good history of the patient has no signs of heart failure, the patient has no previous history suggesting of heart disease. If you run an examination on them and there's simply no reason to believe that this patient has any of these things, and they do not have comorbidities like DM, hypertension, CKD, the requesting for an echo in such a patient may not be appropriate unless there is reason to believe. Just age by itself is not a good idea. It is the ones who are usually above 60 years, and that's when age starts to become an issue. That is studied from high-income countries. We do not have our own studies to say 50 is the one, but based on the WHO, UN, Ugandan, because the life expectancy is about 60 max, elderly, it starts at 50. So unless you have a hospital protocol that says 50, you're going to expose patients to unnecessary investigation, for which you will not use in directing therapy or in directing the anesthetic. That said, even someone may say, what if there is something there that you don't know? Well, that's a very small percentage of patients who are asymptomatic and have been asymptomatic for years, and there's still something going on in there. So it is not standard, or it does not fall into the category that age above 50 do an echo. I would probably go for a higher age, and I would go for patients who have comorbidities, or patients who have a history of cardiac disease or vascular disease or cerebral vascular disease. Those are the things I would probably go for. Yeah.
Okay. Thank you.
Of course, lung disease. Of course, lung disease also. If you have lung disease, I would probably want to look at your heart, simply because lung and heart are very interlinked. So yeah, those are the patients you want to look into.
Okay.
Yeah.
What about you talked about using dobutamine for the pharmacological stress echo. Do you do those routinely here, or is it not yet?
The truth is, the use of some of this medication is not routine. And so if you request for a stress test, other than we have a treadmill that can be used for that to speed up the heart rate, and they usually can connect an ECG on you. But the use of dobutamine, not so much. I would probably ask some of the cardiologists if they've done it, but I haven't seen it being done, and it probably will not be done. And that may be largely related to the familiarity of the use of the dobutamine stress test. But the exercise stress test may be done. But for a patient who cannot have an exercise stress test, you need the dobutamine stress test. And in that case, there has to be someone. First of all, it has to be in a very controlled environment in case the patient gets a myocardial infarction. It has to be in a scenario where you have support for ACLF, and it has to be under a scenario of someone who is familiar with the use of the dobutamine and knows how to titrate it And the patient has to be on continuous telemetry to make sure that you're able to detect one, the heart rate itself, and then number two, be able to keep up with the vitals and make sure they are within acceptable ranges. So it's not going to be routinely done. At least if you request for it, you probably not get it done. And then, of course, the other thing is that when you request for it, the cardiologist will also perform their own assessments, and in most instances, they may decline one way or no another. I whether one of those on maybe the unfamiliarity with performing the treatment.
Okay. I hope that's clear for people who are wondering about the vitamin. I have one more question about the right ventricular systolic pressure. Someone is wondering, is it from the presentation, they've picked that it's mostly related to the tricuspid valve. Does it have any relation to the systolic pressure? Like people who are hypertensive, are they likely to have higher right ventricular systolic pressures as well, or is it only with the tricuspid valve?
So if you have systemic hypertension, the ventricle you have to be worried about is the systemic ventricle, which in normal people should be the left ventricle. Those patients should not have tricuspid regurgitation. The ones who have tricuspid regurgitation, there are basically two compartments of circulation. There's the systemic and the pulmonary circulation. If you have very high pressures in the systemic, the ventricle will have the problems. If you have very high pressures in the pulmonary, the right ventricle will have the problems. And so the valve next to the ventricle is the one that will take the hit. The mitral valve is extremely strong compared to the tricuspid valve. It is, first of all, the only bicuspid valve in the heart, and it is built to handle the backward pressure of the left ventricle. So even when the left ventricle contracts with so much force, the mitral valve in a normal patient will not open. The tricuspid valve, on the other hand, just a little bit of increase in the pulmonary pressures and it will give way. So when you're calculating the right ventricular systolic pressure, presence of tricuspid valve regurgitation increases the accuracy of measuring the right ventricular systolic pressure. And oftentimes, because of the increased backward pressure, your IVC dilates, the right atrium dilates, and so we can estimate the CVP or the pressure in the IVC using that, and we add it to the pressure across the tricuspid valve, and then we get the right ventricular systolic pressure. I don't know if that answers your question.
I hope it does, because I think the concern seemed to be more about if the systemic systolic pressure would affect it.
No, really. No, it doesn't really affect it. Because remember, there is a pulmonary circulation that is between the left atrium and the left ventricle and the right ventricle. And so that pulmonary circulation is a good buffer. So whenever you have issues on the left side, while the left ventricular failure tends to lead to right ventricular failure, it needs time for that process to happen. And so over time, of course, the commonest cause of right ventricular failure is left ventricular failure. But there's so many other reasons why that is the reason. But having just hypertension on the systemic side does not mean you have hypertension for the right side. It doesn't. It really means that you have to first get left ventricle to fail, or you must have a very bad valve like a mitral stenosis that causes backward pressures into the pulmonary tree that then will affect the right ventricle, and then that will start to happen. But high systemic pressures will not lead to high pulmonary pressures because of the valves.
All right. Thank you for that. So we have some more questions. So in one of the cases you had, like that, you talked about a patient who, in some scenarios with these patients, you'll need to counsel a family. You'll need to talk with your multidisciplinary team and establish goals of care and all that. So if you had a patient who has an emergency, but with bad ejection fraction. And it's a do or die surgery. Their life depends on them getting that surgery. How would you approach it?
Yeah, so those are some of the dilemmas that we are probably going to encounter. Now, there are two angles to look at this. Thankfully, emergency surgery does not mean instant surgery. It means that you have time to optimize and get this patient in at least within the next 3 to 6 hours to have the surgery done. So you can have a bit of time to do that and also have a chat with the family. But if you have a surgery, let's say patient has end stage heart failure, they have dilated cardiomyopathy, ejection fraction is 15%. I've seen a patient who had ischemic heart disease, had the myocardial infarction before, and they have had 2 stents. Their ejection fraction is 15. They've been on so many medication, and now this patient gets intestinal obstruction, and they need a immediate emergency surgery for this particular case. Again, always remember, it's not instant. Emergency does not mean instant, and so you have a bit of time to discuss with the family the consequences of going ahead with the surgery. Of course, it may help relieve the pain and the discomfort that comes with the intestinal obstruction, and that may be the goal, to palliate the patient to that level. And so the goals must be set before you go in, and the family has to know that we are going in, but these are the consequences. They also have to know that the care that you're going to provide either is going to be suboptimal postoperatively, or it's going to be almost exactly what they would need to give them a good chance. So if you're in a scenario where the care is going to be suboptimal, you have to be very realistic with the family and let them know that the odds of us making this out without the optimum care that they need is very low. And so the idea here is, yes, it's an emergency, agreed. However, you have to also consider that the surgery is, in this case, yes, you may say life depends on it, but remember, the surgical risk, emergencies by themselves, actually, I probably didn't talk about this. Emergencies are separate from elective. The risk categories I put there in terms of 1%, 1 to 4, and then 5 and above, those apply to elective. Emergency by itself carries a risk of about 10 and above. Now, if you add in a very bad EF and the patient has 2 times the risk of death, then odds are this patient is not getting off the table. If you think about a patient who has, I got concerned about a mother who had severe mitral stenosis, and they needed an emergency cesarean section in a place that did not have capacity to give a general anesthetic, and all they had was a spinal anesthetic. In that case, you have 2 patients to deal with. And then, of course, there's a possibility that this young patient would actually be controlled and transferred to another place. So do you proceed with the surgery? In that case, it may be okay to proceed because valves can be handled much better than function. So you have to weigh on the severity of the cardiac disease that they have, the ability for you to optimize it even postoperatively, and when it comes to function, it's really difficult to optimize an ejection fraction of 10% or 15% compared to a severe mitral stenosis. So you have to judge that based on the patient, their current status. So don't just use the echo. Use the echo to support your decision, but not the echo to make the decision. I hope that answers. It's a difficult situation. You need more context to make sure you answer it appropriately. Yeah.
Yeah. What I've learned from that is to be brave and communicate properly with the family and not rush, even if it's an emergency surgery. It doesn't mean that you have to do it right now.
Yeah.
And so what if it was an elective and you're going to optimize the patient? In our setting, what exactly do we do? And let's say I'm in Bombo Hospital. I've got a patient with ejection fraction of 25% and they have a valvular defect, what exactly do I do? Do I refer them to the Heart Institute so they can be optimized from there? And what exactly does that optimization even mean?
Yeah, so the thing about optimization is it's a multidisciplinary approach. Most instances, when you need an echo and you send to a cardiologist, please do not think of cardiologists as echocardiographers. They are cardiologists, and they can help in optimizing this patient in terms of putting them on medication that will allow their heart function to improve from a very severe state. For example, if it's a New York Heart Association 3, they could move to New York Heart Association 2. If it's an elective case, you may give them a couple of months. I have handled some of the cases referred by cardiologists for patients whom they've optimized for about a month or two. And the patient who came in and they couldn't climb a flight of stairs can actually now climb a flight or two of stairs without breaking down too much. So it is really important that you get them to a cardiologist who is going to put them on medication, monitor them for that period of time. And if the cardiologist tells you I cannot get them any better, then you have a very candid conversation with the patient about their chances, as well as the surgeon. I know sometimes we think surgeons may be unreasonable, but when you let them know about the realities of what to expect, of course, this does not mean to everyone, but they're usually extreme outliers. Most of them are very reasonable individuals who will understand that if this patient dies on table, that will not bode well with their own practice. So you have to look at it in that perspective. So optimization simply means you have time to give this patient medication to improve their heart failure, optimize if it's second mitral stenosis and they've had a tachycardia. Most of them will have AFib. They need to get well controlled so that their tachycardia becomes a normal heart rate, so that you can take them in with less worry about them getting tachyarrhythmias on table and putting your cardiac output in this patient to a much lower state. So that's what optimization really means. Think of it as multidisciplinary, get cardiologists on board. If there is CKD on board, get nephrologists on board and make sure that this patient is in the most optimum condition to withstand the impact of the surgery. Otherwise, they will not have enough physiological reserve to withstand the physiological stress of the surgery after it's done.
Okay, thank you. We are going to answer just one more question. Cornelius, what do you consider an old echo?
An old echo is one that is before the patient's condition deteriorated. That is an old echo. Or before the patient's condition, any changes in the patient condition between the last echo and the patient now, that will be an old echo. So so it can be that maybe if I did it yesterday and today I'm in a different state, I've got a myocardial infarction and I'm not breathing well, I need another one. Yesterday's echo is old. So if you think about it that way, then you'll be able to say, okay, this patient has an old echo. An example in this case can be that if a patient comes in and they had heart failure the first time they presented, they're optimized and they're improved, and today they come in and maybe an echo 3 months ago showed improvement, but now the patient is able to withstand exercise, they're able to walk around, they're able to do a physical activity. Why do you need an echo on that patient? The one 3 months ago is quite reliable. However, again, that has to be in light of all the other factors, not just the exercise tolerance, but also has to be in light of, okay, what did they have an AFib then? AFib predisposes to thrombi in the heart itself, intracardiac thrombi. If they had that, you probably need another one to make sure that there is nothing going on within that heart. Some of them may have LV thrombi. So if you have a dilated cardiomyopathy and they have improved, I probably want to look in again, because the moment you have a stasis, then you have to consider that you get Vacho's triad coming in, and then you get a thrombus. So this is something that you have to look into. If someone has had an echo over 6 months and their condition has been fairly stable or improving, then your rationale for having an echo repeat should not be based on this patient is a cardiac patient, I need another echo within the last 1 week. No, it should be based on their physical function, exercise tolerance, there any changes within the last couple of months that could tell that they probably have an issue going on that you may not know. Then yes, having an echo done done again before the surgery may be important. In high-income countries, they may, if a well-optimized patient, they consider 1 year, an echo done within the last 1 year in well-optimized patients. But now, if you live high-income countries, come to low-income countries, accessibility to these services is little. Delays that prevent patients from coming into hospital or missing their appointments. So all these things have to come in. When was the last appointment with a cardiologist? If it's been a lot of months since the last echo and they haven't gone back, then you probably need another one. So it has to be really contextual, and this have to factor in that high-income countries that say 1 year, those guys have patients who are literate, more literate than ours. They probably seek healthcare much more than our patients. They attend all their appointments. In our case, that may not be the idea. So I'm not giving you a straight up answer. What I'm asking you to do is to use the requirement for a new echo in context of all these things that surround the patient's social history, as well as their cardiac history and any other changes that could have happened within that period of time since the last echo, to determine whether you need the echo report, the echo test to be redone. Thank you.
Okay, thank you, Cornelius. Final words. If somebody is going to go off the internet, is never going to watch this recording, is going to probably forget some of the things you've said, what are 3 things you'd want them to take from this?
All right. I hope the recording isn't lost, but the first thing that you have to know about echo reports is please look at who has done that echo report, because that will clearly give you an idea of the competencies of that particular individual. And we've seen echo reports done by radiographers. They are largely different from those done by cardiologists. And we have some people printing fake echo reports in Uganda. And so you have to look at also the signature. You can see sometimes this thing was just printed and maybe whitewashed and then photocopied, and then someone put a signature and made the patient pay. And so that will tell you the validity or the genuineness of that echo report. The second thing, look for inconsistencies within the echo report that do not tie in with the hemodynamic changes of the lesion that has been reported, like the one I showed you earlier. Once you have those 2 down, then odds are what you have is a fairly accurate echo report, for which then you can go ahead and read. The final thing about echo reports is that you have to, I mean, it doesn't hurt to consult about the echo report, even when you think you got it. I think it's better to consult, especially when you have systolic ejection fraction of less than 40. That is where you probably want to consult about that echo report. Once you see that, I think it is only prudent for you to consult and see if your thoughts are consistent with what a cardiologist or a cardiac anesthesiologist, and I see some of them here, would think about that patient. It helps. Yeah. Those are my 3 take homes.
Great. Thank you very much, Cornelius, for this presentation. It has been wonderful, educative. There've been a lot of comments saying thank you. And for everyone who's still on, we'll share the recording to our YouTube and our website, and we'll let you know when we share it. Thank you once again for participating. This CME has CPD points accredited, and if you have any difficulty with what that means or figuring out how to get them, please email us and we'll help you out. Once again, thank you, Cornelius, and thank you everyone for attending and participating. We look forward to seeing you again next month. Have a good evening, get home safe, and enjoy the rest of your week and the weekend.
All right, thank you, Bernadette. Good night, everyone.
Good night.